All righty. Oh, there we go. Okay, hopefully everyone can hear me. Um, First, I wanted to say thanks to the Eastern Oregon EMS conference for having me back for another year. I'm surprised that you guys liked me that much the first year that you wanted me back. So thank you for that. My name's Derek. For those who don't know, I'm just going to start talking. I'm assuming everyone who is ready to attend has attended. I am a registered respiratory therapist. I've been one for about 14 years now, which makes me sound older than I look, I promise. But I've had most of my career out in Colorado, where I'm from. And I've worked in a variety of different hospitals, University of Colorado Hospital, Lutheran. I've also been a clinical educator for the local respiratory school out there, Pima Medical Institute, for a couple years. And then one day I decided to come to Pendleton. Don't ask me why. No, just kidding. But so currently, you may have seen me around. I'm at St. Anthony Hospital in the cardiopulmonary department. But so today's topic is going to be a little bit different. My talk is going to have a little education in there, but it's going to be more of like a point of view, kind of wanting to reflect back on what has happened the past couple of years. I don't know if you guys have heard, there's this crazy virus out there that kind of swept the world. And this is kind of going to be just a more presentation about my experience, what I've seen. And hopefully you guys enjoy it. One of the things that I did want to mention, though, because this is a pretty controversial topic, I wanted to put a disclaimer out there and to just kind of let everyone know that during the time that I was researching this, this was the current evidence-based practice that I had at the time, and literally it was changing by the day. I would go and revisit this PowerPoint here and there, and I had something on here that was wrong because it changed the following day. So at the time that I made this, it was as current as I can get. And I want to ensure and make sure that you guys still just continue whatever policy or procedures, guidelines that you have in place at your facilities and or departments, still continue to use that. But so you might hear some things that might be not quite accurate, or might even be opinion based, again, because this is kind of like a POV PowerPoint. So with that, let's get started. So in the beginning, back in the year 2020, we had kind of gotten wind that there was this virus that was going around in China. And well, this was actually in December range when we heard about this virus. But the first US reported case was back in January of 2020. And it was a patient that was visiting Wuhan, China, and just happened to live up north in Washington State, of course, right next to us. And so, of course, with that, everyone started to freak out. And by March, we decided to go ahead and shut down the entire country. And no nothing, no outings, no restaurants, no nothing. I mean, everything shut down. And at the time, they were like, "Yeah, we'll just go ahead and shut it down for a couple of weeks here." And so, of course, we're all thinking what these guys are thinking. Oh, a couple of weeks with the family, what could go wrong, right? Every time I see his face, it just like a picture is worth 1,000 words there. Look at that. Like just, oh yeah, you could see the craziness coming out. But that's pretty much how we all felt, was basically, it seemed okay at first, but as we all know, it kind of went a little chaotic. So of course, like I said, everyone started freaking out. Everyone started panicking. There was absolutely no toilet paper. Nobody could find it. You had to wait in lines, and even then weren't guaranteed to get some. Remember, there was no barbershops, so we're all running around with no toilet paper, and our hair all looks like 1980s rock bands, which was definitely a genre. I don't know if we wanted that to come back so soon. And then, of course, there was no cleaning supplies, no disinfectants, no hand sanitizers. You know, if you wanted to get a bottle of Purell hand sanitizer, good luck, you know. And of course, the one thing I think that we could all take away from the year 2020, Tiger King. Don't forget about this dude. I don't think there's any explanation needed there. I kind of wonder if that was going to be as successful if this pandemic didn't happen, because I watched that and I didn't think that it was as good as everyone kept saying. But anywho, so then the year kind of goes along. Things start to reopen. And so I don't know if you remember, they started to open up restaurants and only occupy them at a certain capacity, 25% capacity. That's when the FDA decided they were able to approve the EAU, or emergency authorization use, for antiviral medications and vaccines that they started to develop. So we're thinking, okay, yeah, great, we're going to be able to go back to regular life. But wait, there's more. Does anyone remember variants of any kind? Delta? Anywho, there was also mask mandates, which kind of threw everything in a loop as well. And then don't even get me started about those murder hornets. Remember those? Jeez. Then year 2021 happened. And this is going to be kind of more of a what I've seen from start to finish, kind of with multiple patients that I've had. And so I think this part's going to be kind of cool, because not everyone got to see the full picture, you know, especially with the EMS crew. They just kind of start, get things rolling, and then don't really know what happens from there. So what happens in the very beginning is usually EMS would get a call that there was a patient complaining of worsening shortness of breath, work of breathing, chest pain for 3, 5+ days. And usually when you guys would show up, there would be some vital signs that would be indicative, of course, of, you know, low sats, shortness of breath. Usually oxygen would be placed on the patient, and then you guys would head them on over to the ER for further evaluation and treatment. And then during the ER stay, if we were able to, we would try to fix them up and get them back out of there. But one of the main criteria that a lot of these people were meeting were oxygen requirements. If we couldn't get them off that oxygen during that ER visit, that was pretty much a ticket for admission to the hospital. And so once they were admitted to the hospital, we would usually start off with just regular wall oxygen at a low flow nasal cannula, preferably. If they were able to tolerate SATs, we were actually accepting lower SATs than normal, about 85% and higher, which, you know, now I have come accustomed to seeing 85 and thinking, oh, it's fine. But back in the day, like 85 is not good. Typically, especially like at our level, 93, 94 and higher is usually what we want. So seeing 90, 91 is not even good, to be honest. If we were up in like altitude, like back in Colorado, where I'm from, if we were, up there mile high altitude, then 90 would be acceptable. But for the altitude location here, usually like 93, 94 and higher. So we would start off on low flow if possible, which was anywhere from 1 to 6 liters. And if they weren't able to tolerate that, then we would shoot up a little bit more. And so we would go to a high flow cannula. So the typical nasal cannulas only support a low flow. So this particular high flow cannula is a brand new different cannula that we would have to then set up on the patient in order to be able to support 6 to 15 liters. You can't take a low flow cannula in theory and shoot it up to 6 to 15 liters because it wouldn't give you a nice laminar flow through the tubing. And so it would just not really cause much oxygen output. And so you would have to then install another device that offers that high flow cannula. During this time that we were deciding what type of oxygen device to put the patient on, we would also start off with the medications. And the early medications back then were the main one was remdesivir, which was an antiviral, and then dexamethasone, which is a steroid. But there was a plethora of other medications that were initially started because we just didn't really know at the time what would help with this. I mean, they were giving vitamin D and vitamin E and all these different medications just to kind of see what happened. And then we would also do a technique with the patients called proning. And for those who don't quite know what that is, when you are laying on your back, you have your chest wall cavity, you have your heart, you have your adipose tissue, all of that weight is pushing down on your lungs. And so you aren't able to really expand your lungs fully. So proning is where you would have that patient lay on their belly or their sides if they couldn't lay on their stomach. And what that does is it allows for that weight and that chest cavity and heart and all those things to basically take off of the lung so that lung can now expand. And usually when you see people proning, you would see a higher percentage of oxygenation, so their sats would be better. And so we would have them do that fairly often. I think every 2 hours or something is what we had them going at to do side laying and belly laying as tolerable. But some of the patients were still not oxygenating well. And so what we would then do is continue on with the next type of devices that we have. And this picture here on the right is called the Vapotherm, which is just a brand. And there's plenty of these types of devices out there. What it is though, it's a much higher flow device than what the regular wall cannulas can do. So the wall, in theory, that only goes up to 15 liters. These devices, these high flow devices, they can go all the way up to 40 liters, even up to 60 liters. Some of the companies that they can offer 60 liters of flow. So it's just a massive amount of flow at this point. Because there's such a high flow, you are pretty much asking to dry those lungs out. So what we would do, and this device offers this, is it offers heated humidification. And so that red number there that says 37, that's degrees Celsius. And so we would heat the air, this flow that's coming out, at body temperature. So that way we don't dry those lungs out as bad. And then the beauty with this device is it also offers for, it has an internal blender. So it offers for us to be able to dial a percentage of oxygen. And of course, you can choose anywhere from 21%, which is room air, all the way up to 100% if you need it. So typically, the people that weren't able to tolerate that 15 liters, we would throw them on this device. And each one of the manufacturers is probably going to recommend a different starting point. And so just follow up with whatever, protocols you guys have. Ours, we usually start them high and then try to titrate them down low. So we would start them off all the way at that 40 liters and possibly even 100%, see how they're satting, and then kind of titrate as tolerated. I mean, at this point, all we're just trying to do is keep their oxygen sats up. But some people still couldn't handle that. Even on 100% FiO2 and 40 liters of flow, their sats were still low. And so we would even throw like a non-rebreather mask or an oxy mask, some sort of mask on top of their face as well, going at 15 liters to just try to keep their sats above 85, along with continuing the medications. And, still this device, because it's a nasal cannula still, it still allows for them to be a little bit mobile. So we would still have them trying to prone or side laying as tolerated. And so one of the things that I wanted to kind of just show in comparison was what these COVID lungs look like. Why are we struggling to oxygenate these patients? Well, this lung here on the left side of the screen is what a normal chest x-ray looks like. You can kind of see the lung is nicely dilated, and usually you can tell that based off of counting the ribs. You want to see 8 to 10 ribs, which are those white kind of horizontal lines. You want to see about 8 to 10 of those, which means that they have a good open dilated lung. You have the nice angles at the bottom there. That's, kind of where your diaphragm sits. And so you want to see nice angles there. You can see the lung vasculature that goes all the way to the chest wall cavity. So a nice normal open lung. And a COVID lung typically looked like this. Absolutely no air movement. There is just no dilation, just a really terrible looking lung. And so this is why we were struggling to oxygenate them. There was this massive shunt, so to speak, or barrier that was just preventing us from being able to oxygenate, ventilate these patients. Just a sidebar, those arrows are just pointing to, there's this particular x-ray that I saw had a few central lines placed, which were those white arrows. There was kind of like a jugular line of some sort, and I want to say that one was like a mid-clavicular line, or maybe it might have been a PICC line coming from the arm. But anywho, those are just lines that are pointing out, and that black line, I believe, was an NG tube or an OG tube that was placed. So just disregard those lines. I'm just talking about the specific lung look or texture, if you want to call it that, of that COVID lung. So not good. I mean, absolutely terrible. So If for some reason that patient still was not able to tolerate that Vapotherm, that picture in the last one, which was that heated high flow device and a non-rebreather, and they weren't able to maintain their sats, then we would go ahead and reach for our next machine, which was this device here on the right side, which is a CPAP, or you'll hear it called a BiPAP machine. CPAP and BiPAP are just modes of ventilation. So you'll hear it called one or the other, but those machines typically offer both modes. And so CPAP, just to recap from my talk last year, is continuous positive airway pressure. So basically it's one continuous static pressure that's going at whatever we set it at, 10, 12, 14. It's just going to stay at that pressure during both the inspiratory and expiratory cycle of the breath. So they're basically just breathing on top of this pressure. And we found that this was pretty helpful with these patients that were not able to tolerate this Vapotherm and non-rebreather kind of combination. That CPAP was just nice enough to be able to open the lung up, stint it open a little bit, open up some of that alveoli, those small air sacs in the lungs, to be able to just oxygenate these patients. And so it was interesting. We could take somebody off of the 100% from the Vapotherm, and they would be on that CPAP at whatever pressure, 14, 16 was usually what we had set, and have their oxygen down to like 50 or 60% rather than 100. So it seems like they really did respond pretty well to that pressure. But, you know, these patients would then we would either jump back and forth between this and the Vapotherm just to give them a break off of this machine. And those were the kinds of patients that we would still be, you know, just due to the influx of patients that we had, those were the patients we would probably still keep on the medical surgical floor. But if they were requiring this pretty much continuously, more often than not, they were usually transferred to the ICU or the critical care unit, because they're sick, you know, they're really sick if they're requiring a continual non-invasive machine at this point. Once they, you know, were critical care criteria, we were pretty much trying to do everything and anything we can to prevent these guys from being intubated. And usually you're probably saying, well, Derek, you know, if they're this bad, you know, why not just intubate them? Well, what we were finding was that, and this was the most current evidence that I was able to see, this was a good peer-reviewed study. Basically, once you are intubated for COVID-19, you had a mortality rate of anywhere from 50 to 97%. That is absolutely terrible. So basically, if you were intubated, it was kind of like a death sentence almost. Not everyone, but it was a lot of people. So usually we, in the beginning, we were intubating these people left and right and shipping them off. And then there was not good prognosis of their treatment, and they usually didn't do well. So the evidence started to show that you prevent intubation as long as possible. And this was a great study to kind of see why. Once you were intubated, we at that point, that was kind of the end of our road here. We would send them to a different facility, because at this point they're needing a much higher level of care, much more doctors involved, techniques, treatments that we just can't offer here at a small critical access hospital anymore. And so one of the things that some of these hospitals were doing was a device called ECMO. And what that device is it's placed in the lung or the heart, depending on which kind. There's two different types of ways they do this ECMO based off of where the placement of the cannulas are. It literally will take the blood out of the body. It sends it into this oxygenator that will remove CO2, and it will oxygenate that blood, and then it sends the blood back into that body to then be sent to the remainder of the organs. So it's those external heart lung machines that you kind of hear in TV and whatnot. And that is a pretty severe machine to be working with at that point. So that just kind of gives you an idea of like unbelievably how sick that patient would have to be, that we need to remove the blood from their body because their lungs just cannot work. They're not oxygenating this blood anymore. And so if that still did not seem to work, usually they would keep them on for a certain time frame and decide whether or not if there's improvement at a certain time frame, and if not, then they would start having a conversation with the family and about removal of all this stuff and pretty much end of life or what's the word I'm trying to think of? End of life care, so comfort care measures, there we go. And and that, as you saw in that study previously, up to 97% of the time this was happening. So this was a rough go, having to see these patients, and not to mention they still have COVID. So it's not a typical end of life where you get to have the family all there saying their goodbyes. No, you're not allowed in the room. In the beginning, you weren't allowed in the hospital even. So they were FaceTiming and doing all this stuff. Some people have been able to start to kind of be outside of the room now. But just think of how like awful that has to be, that this was the last days of your life and you don't even get your family member there to be able to be in person and say goodbye. So it's awful. And this is what we were seeing, even to this day. So basically, I know that this is like pretty opinion based, but it's just, it just shows the importance that masking and vaccinations do show that they are able to be effective. And I actually have a slide coming up here that kind of shows a little bit of current data trends. But so basically, every time I walk around now, I'm so scarred from everything that if I hear you coughing, nope, I'm gonna turn around, I'm gonna look right at you. You got that COVID or what? Like, you know what I'm saying? So, because I don't want to end up like that scenario we just went through. So anywho, all jokes aside, this is that data that I was showing. And so again, I was doing this was August then. I thought it was September when I was looking up this research. But I just wanted to show you this bar graph here. A lot of people have their own opinions about the vaccines, but just looking at these data points, that line that's a nice steady low line that's horizontal all through those months, January, February, March, all the way through to August, nice and steady, meaning those are the vaccinated people that were hospitalized. So they were vaccinated, they got COVID, and they were hospitalized. That bar graph, or that bar line that's above, is the unvaccinated, and it just kind of is a nice visual representation of you know, the population of people that are mostly hospitalized. It's not, I mean, it can be the vaccinated patients, but most of the time it's these unvaccinated patients. And I mean, look at how high of a spike that was back in August. And it kind of would go in those waves. So we would get these surges. So it's just kind of crazy to see that. You know, you hear it talked about all the time, but there's the data. I mean, it's, you know, they're gathering stuff every single day. So the single most important thing to do would be to get your vaccine if you're able to, you know, to be able to prevent, not prevent, but protect yourself from getting COVID. And if you do get COVID, it will at least reduce your chances of being hospitalized versus unvaxxed. This was a nice little chart that I pulled from the NIH, just kind of showing, and again, this was back in August then, current treatments at the time for COVID-19. And it was just kind of cool how they split these boxes up from being hospitalized but not on oxygen. And then they, you know, they categorized it: being hospitalized while on oxygen, being hospitalized while on high flows and non-invasive, and then being hospitalized while being intubated and on ECMO. So you would be able to kind of follow this little panel recommendation. And most of it is kind of what I talked about, which was the remdesivir and the dexamethasone. There's a few other ones in there, which this next slide I have here is kind of goes a little bit more into, you know, the dosing and, you know, how often to give it. And so, but there was a whole number of treatments that, you know, didn't make this list that we were doing just at the time because we didn't know. But so it's kind of nice to have a little chart now that we can kind of reference and go from there. So that's pretty much it for my presentation here. I know I kind of ran through it, but I know that this was the last talk, and I know you guys are antsy to hurry up and get on your Saturday night. If you have any questions, I'm willing to answer them, but I do want to kind of just remind you that I am a respiratory therapist. So if I feel that there's going to be a question that's kind of above my job title, I don't know if I'll feel comfortable with asking or answering it. But I can kind of, again, just, you know, answer some that I feel qualified to.
All right, Derek. So one of the questions was long haul COVID. Have you seen any repeat patients back in long haul issues or repeat issues?
Yeah, that's a great question. I should have added that. I have, and the thing, I haven't noticed a trend of why somebody would get long haul COVID versus someone else. The main people that seemed that were getting COVID anyway were people who had a few comorbidities, and it seemed like most of them were obese, diabetes, and yeah, mostly that. But as far as that long haul, there, you know, I have people that, you know, don't meet that criteria at all, and they're still testing positive. I even tested one in the ER just the other day. They told me they had COVID back in June or July of last year, and they tested positive still. No symptoms other than a few people that were still reporting that their taste and smell are not quite there yet, which they are doing studies on how to get their taste and smell back. There was some sort of aromatherapy type treatment where they make you smell this particular smell, like a steak in it, you know, like the seasoning and stuff. They make you smell that over and over and over again until you pretty much embed it in your brain, letting you know that that's what steak is again. And so it's kind of interesting. This will be something interesting to kind of research when, you know, later down the years when we kind of figure all that out.
What kind of improvement did you see with proning? How dramatic was it? What were kind of increases you saw?
Yeah, I wish we don't really have like at our hospital, we didn't really have like physical data to be able to back up, but it was almost instantaneous. The moment we had them flip to their back, they would go from 82, 83% up to like 94, 95%. But again, once they, you know, moved or flipped back, they were kind of right back down to you know, lower 90s again. So as far as how effective was it, I mean, it's very effective. The only problem is you can't stay prone for so long. I mean, because you're asking for, you know, pressure source. And even though we'll add pillows and we'll add, you know, pads like Mepilex pads and stuff to try to prevent those pressure sore areas, you know, it's not recommended to do it for very long. And in fact, with people who are intubated, that we prone, I mean, each hospital is going to probably have their own protocol, but the normal time is about 16 hours total to prone, and then you flip them back again, regardless of their condition. So you don't want to do it. You can't do it for very long, but when they were proning, I mean, it worked very well.
What about long-term scarring of the lung tissue, or is it more of a vasculature issue?
There is some, no, there's definitely scarring of the lung that happens. And in fact, that's a great question too, because what we've started doing is, and this is probably gonna just kick up and be probably a yearly thing now for some of these patients. We're doing pulmonary function tests on them to measure their lung functions and to be able to just kind of keep an eye on, you know, how scarred and how affected their lungs are. We just did one the other day with a patient that had COVID last year, and he was just kind of doing a pulmonary function test, and yeah, he had lung functions that were definitely decreased from his prior one. So I mean, it's definitely scarring the lung, not just vasculature, but just in general.
All right, I think that was the last of the questions.
Yeah, those were great questions, actually. Yeah.
I know, just, you know, anecdotal, for those that know what I do, I'm a chief of an agency, and we have one of our medics that was just before vaccine became available, a few months before that, he was in the ICU for 8 days and off of work for 60 days. And he's a healthy 38-year-old man that now has AFib as a consequence of this. So you don't know, and it's kind of the weird thing about how this is going to affect people mostly. Like, we know we're talking about today, it's a respiratory issue, but yeah, there are a lot of other things. So we appreciate that. But we've come to the end, my friends, of this year's conference. Thank you, everybody, for attending. Like I said, your certificates of attendance for each of the sessions, you should have them within an hour of it ending. All these presentations will be on our YouTube channel. And then look for, you know, our Facebook page. We're probably going to come out. We're already talking about what are we going to do next year. You know, we'd like to be able to be back in person in some fashion next year, but we're talking about some kind of hybrid model. What we know by doing online, the great thing of online, of a virtual session, is that we've got people this year from Pennsylvania, New York, Illinois, Ohio, California, I mean, all over the country attending this year. So it is nice to make that available, and especially, you know, travel is hard. So you might see some kind of hybrid next year, hopefully some kind of in-person. So we hope to see you then. Send us any emails or questions, follow us on Facebook, and we will see you guys hopefully next year.